El doctor Carlos Guido Musso, quien hará la coordinación de la sesión, es un nefrólogo con doctorado en fisiología renal, en nefrogeriatría, y actualmente trabaja con el Hospital Italiano de Buenos Aires. Además, es investigador de la Universidad Simón Bolívar de la ciudad de Barranquilla. Si nosotros miramos la situación, o hacemos un recuento, pues al día de hoy, el COVID ha afectado a más de 4 millones de personas y son casi 300.000 personas que han muerto. Sin embargo, también vemos que hay un número creciente de personas que cada día se están recuperando. O sea, esto quiere decir que un tratamiento oportuno es un tratamiento que puede llevar al éxito y a la recuperación de las personas. La situación nuestra en Colombia es de 12.930 casos. El primer caso se confirmó en Colombia aproximadamente para el día 6 de marzo. A partir de este día 6 de marzo, al inicio, las medidas adoptadas por el gobierno de contingencia surtieron un efecto y vimos una curva que estuvo pues muy aplanada. Pero esto también se debía al inicio en que no había muchas pruebas disponibles para realizar los PCR. Una vez que ya se comenzaron a realizar los PCR en las distintas ciudades de Colombia, el número de pacientes positivos acumulados comenzó a subir. Asimismo, esta fecha de inicio de la cuarentena, que fue el día 25 de marzo, también nos ha permitido ver cuáles han sido los recuperados que se han ido acumulando. Si vemos el estado de la situación, la mayor parte de los casos pues son casos leves a moderados. La enfermedad cursa asintomática, casi que en un 15% de los pacientes. Y aproximadamente 1.35% de los pacientes llegan a las unidades de cuidados intensivos. Tenemos actualmente pues una mortalidad asociada a estos casos que llegan a cuidado intensivo relativamente alta, con una tasa de letalidad del 4.1%. Esta pues es a grandes rasgos nuestra situación en Colombia. Siguiente. Bueno, vamos a iniciar entonces nuestra primera charla con el profesor Claudio Ronco, a quien damos las gracias y es un honor tenerlo a usted en Colombia y en otras partes del mundo que posiblemente nos ven en el día de hoy. El doctor Claudio Ronco ha sido pues presidente de la Sociedad Internacional de Nefrología, al igualmente es director del departamento de nefrología del Hospital San Bartolo de Vicenza, Italia. Es profesor externo de la Universidad de Virginia, además de esto de la Universidad Fudan y Caotón en Shanghái. Es una persona muy reconocida, un científico muy reconocido a nivel mundial. Tiene más de 1.300 publicaciones, 70 libros, 125 capítulos de libros y ha estado en muchas lecturas internacionales, en congresos, en todo el mundo, siempre enseñándonos y educándonos en los aspectos de lesión renal aguda, del daño endotelial, de la sepsis, del manejo de esta misma lesión renal aguda. Es editor emérito y ha contribuido mucho a la nefrología y a la medicina cardiorrenal y a la Sociedad Internacional de Órganos Artificiales. Muchas gracias, doctor Ronco. Es un honor tenerlo en Colombia y poder escucharlo y aprender de usted y de esta experiencia que ustedes han tenido en los meses previos de esta pandemia.
Muy bien. ¿Está mirando mi pantalla?
Sí, señor. Puede seguir adelante, por favor.
Perfecto. Entonces, quiero agradecer a la Asociación Colombiana de Nefrología e Hipertensión Arterial y al doctor Gustavo Aroca y al doctor Musso para ser chairman de esta sesión y por la gentil invitación. Yo tengo un español muy pobrecito y entonces voy a hablar en inglés, pero mi idioma será un inglés muy simple, hablado de un italiano a los amigos colombianos. Yo creo que nos vamos a entender muy fácil. Preguntas y al final podemos probablemente hacerla en español y vamos a ver si es posible. Entonces voy a hacer un switch con el English y un saludo particular de nuestra universidad, la Universidad de Padova, que va a tener 800 años de historia en 2 años desde este momento. Bueno, muchas gracias por esta gentil invitación. El título es ¿Cómo funciona la hemoperfusión? Es un topic muy importante y pienso pero que voy a hablar un poco en un concepto más extenso de cómo el virus COVID-19 ha influenciado la insuficiencia renal y los tratamientos. So we will speak about the virus and the kidney, and issues that are of interest for the nephrologist. This was a picture, 15 of March 2020. You see that mostly Europe was affected after China, and somehow the level of interest for the United States and Latin America was quite limited. But there was a progression over the months and the days, actually, that led to increase in cases in the Americas. And today, you see how much the map of the pandemic has completely changed. Now, here in Italy, and especially in Venezia and in Veneto, where I live, we are familiar with epidemics. And this is a picture from the 14th century in Venice, a place where the term quarantine was invented to leave the people arriving on the boats from the eastern countries for 40 days in a special area of the archipelago to avoid them to bring infectious disease. And also there was a special mask worn by the doctors that was suggested to avoid contagious, as we wear the masks today. Now, we are familiar about the evolution of viruses through species, especially the influenza virus. We had the experience of the aviaria called H5N1 and H1N1, the swine influenza. And before the present epidemics, we knew the SARS, the severe acute respiratory syndrome, a typical pneumonia caused by a coronavirus that appeared for the first time in Guangdong province and caused several cases. Thanks God, this virus has completely disappeared. Bats and small mammalians were involved. Coronavirus MERS from Middle East, causing also a respiratory syndrome, was identified in 2012 for the first time in Saudi Arabia, and camels were considered the source of transmission. It was identified, the mechanism, by transmission of droplets that evolved into possible contagious disease between humans. This is still around as a disease. But today we're dealing with the new virus, still of coronavirus species, family, that has been probably initiated in bats through a small mammalian, the pangolin, and today is transmitted to the human with the jump of species. It was first reported by officials in Wuhan city in December 19, and subsequently in January, it was identified as a specific new type of coronavirus defined SARS-CoV-2 that was basically disseminating the present syndrome. There are a lot of discussion where the origin of this virus is, but there seems not to be evidence to support the fact that this is a laboratory construct, but rather a natural event. Now, knowing what was going on in China, we published on February 6 in Lancet a paper saying preparing for extracorporeal organ support in intensive care. I think this was a visionary paper because in Europe at that time there was no need for extracorporeal therapy support due to coronavirus. But this paper was definitely somehow defining that because it was not possible to anticipate the extent of the epidemic and the number of patients, we claimed that we should be prepared for our intensive care system. Now, we learned that the spikes, the glycoproteins around the virus are specifically linking to specific receptors on the surface of human cells, which are highly expressed in the heart and the lungs. And that's why this invasion of alveolar epithelial cells result in respiratory syndromes. These spikes seem to be the problem related to the virus. And the radiological findings by those who first saw this type of pneumonia was kind of specific and different from whatever has been seen previously. In particular, you see that severe manifestation look like a condition where there are microembolism and macroembolism present in the pulmonary field. Now, immediately we realized that we needed to get prepared, but also we needed to at least consider what to do for the nephrologist point of view. And we published, for example, the urgent need for individual mobile phones, recognizing that a lot of patients with mild infection could be probably managed at home. This is an algorithm for our PD patients with suspicion on COVID at home, where we recommend to stay at home and we manage our suspicion upon spontaneous arrival at the hospital or suspicion while in the ward. And we have a specific algorithm that allow since today, not to have any positive patients among our PD patients. At the same time, we used very much our telemedicine, teleconsult, and information communication technology skills with different type of remote patient management with specific platforms that in our PD patients allow to reduce the number of visits and manage at home all the different options. This is a kind of algorithm that we have depending on the alarms that show up using computer resolution or telephone communication, and only seldom and as a least option the patient is invited to come to the hospital. The same is what we published for the hemodialysis patient, where you can see in blood purification this paper, safeguarding maintenance hemodialysis patient population. And again, we have published a special algorithm, and this can be probably useful for you guys that are now confronting with the explosion to avoid the possible hospitalization and if needed, this should be done in a specific COVID section. Again, we have the case of suspicion of COVID at home, and then we have a special triage depending if it is in the dialysis day or non-dialysis day. Suspicion on COVID arrival, we have set up a triage directly before outside the dialysis center, and the patients are then tested with swab tests, and patients that are already hospitalized are also treated with specific caution, and swab results let us tell what the subsequent behavior should be. Now, in the same time, we also published a paper in Lancet Respiratory Medicine on our concern about transplanted patients. Transplantation, of course, is very important and was continued for hyperimmunized patients, but not for living-related donors, because we were afraid that the PCR test for detection of virus were not accurate enough to preserve patients from specific risk. Now that the epidemic is decreased, we have restarted our program, but we have suspended for at least 1 month, and this was our letter to the Lancet. With time, we started to learn exactly the mechanism of damage at the let's say alveolar level and at the endothelial level, and we started to understand that there was a combination of direct damage and damage derived from the hyperactivation of the immune system. In part, this explained why not only the lungs, but also the heart and other organs were involved in the complex symptoms of the severe syndrome. So we, somehow interested in this, published a commentary in Nature Reviews Nephrology, addressing specific comments related to the cytokine storm, what you call trastorno de cytokinas or something similar. There is a massive activation of the immune system with the release of cytokines and activation of all the cells of the immune system. So there is both an innate and adaptive immune response with high levels of different cytokines, including pro-inflammatory mediators, but also anti-inflammatory mediators due to the response of the adaptive immunity. And this may lead to acute lung injury, of course, may lead to hemodynamic instability with hypotension and need for vasopressor, altered coagulation, bleeding or hypercoagulation were both observed, renal failure, and a systemic capillary leak syndrome with something that somehow resembles what happens in sepsis. Interleukin-6 seems to be the most important cytokine in causing activation of the organ damage in different viral infections, and it is produced by different immune cells. And I think that what triggers further stimulation of other cytokines is exactly this. The cytokine storm induce symptoms like fever, cough, shortness of breath, myalgia, arthralgias, fatigue. Sometimes myalgia evolves into rhabdomyolysis, and the aspects observed in this patient are low albumin, elevated CRP, elevated ASR, elevated LDH, ferritin, and interleukin-6. Anti-interleukin-6 drugs, therefore, have been suggested to block the cytokine storm, like tocilizumab, and this type of drug, other followed by others like sarilizumab or other experimental drugs, seems to block circulating levels of IL-6. But I think that while in summary, we may say that cytokine storm is a combination of pro and anti-inflammatory stimulus, and IL-1 is just one of the cytokines present. The use of a drug that blocks cytokine, specific one, may not be enough to block the entire storm. And so the question is, do we have other options? And if we consider what we learned from sepsis, we have discovered the so-called pro-inflammatory response followed by the anti-inflammatory response that possibly leads to recovery, but in other situations may lead to death due to intractable inflammation, or may lead to death due to a late immunoparalysis due to adaptive immunity. Now, the cytokinetic models has suggested that high level of cytokines in the circulation may be actually somehow removed by blood purification therapies. However, we should not expect probably changes in levels of cytokines, or not dramatic, because we're not aware about tissue generation and by the gradient that takes place between the tissues and the blood. Therefore, we can remove from blood, but we can actually create a gradient to remove from tissues. And this is the base for cytokinetic models that actually may provide some kind of alleviation of symptoms in different tissues and organs. So the idea is not to have a magic bullet for one cytokine, but rather to have a magic shield for the entire storm. And that's why we published our commentary on the rationale for extracorporeal therapies. As we have in sepsis, infection may introduce the concept of altered immune response with high cytokine levels and subsequent organ damage. At this point, we feel that there is a role for extracorporeal therapies, not only to support organ function, but to prevent cytokine damage to different tissues. We have today available special resins. This is a case of a neutral macroporous resin absorbing beads that we have studied. They are made of styrene and divinylbenzene copolymer. They are very biocompatible, and we have studied this. The approach is the following. The viral infection induced pneumonia, but together with the direct damage, we have also mechanical ventilation and possible ECMO that may actually induce a kind of stimulation of pro-inflammatory mediators, followed by anti-inflammatory mediators, with a consequent systemic cytokine release, endothelial dysfunction, and organ damage. If we apply different types of extracorporeal therapies, including hemoadsorption, including hemofiltration with high cutoff membranes, or plasma filtration adsorption, or double plasma filtration molecular adsorption called DPMAS, we can actually intervene exactly in the phase of cytokine release and have a non-specific cytokine blockade. Of course, we are not able to monitor this, but we know that the higher will be the concentration of a cytokine, the higher will be the removal. And so we, being a specific, contribute to protect the endothelium, somehow reconstituting a certain level of immunohomeostasis, protecting organ for further damage. We have studied the resin in a special setup in our institution, different cartridges, and we found no reaction at all with monocytes grown in presence of these resins, showing that high biocompatibility is present. We also studied the possibility to use this in the extracorporeal circulation in combination also with the CRRT, and the flow distribution inside the different cartridges is absolutely optimal, showing the full utilization of the resins available for absorption. So the studies allow us to confirm that the cartridge can be used in conjunction with CRRT with no significant increase in end-to-end pressure drop, and therefore the circuit can be easily managed by our nurses. In the paper, we suggested the possible use of cytokine removal using different approach, such as direct hemoperfusion, plasma absorption on resin after separation, or specific, they call continuous kidney renal replacement therapy. This is crazy for the Americans that want to call kidney the renal replacement therapy, but this is something that I don't understand. Anyway, this is CRRT. And possibly using medium cutoff or high cutoff membranes. Of course, there might be other forms of extracorporeal support, including ECMO, and there might be also the possibility to support the heart and other conditions. Interestingly, in some patients, there may be a superimposition of bacterial infection, so that you have to use what we call sequential extracorporeal therapies that may be basically initial removal of endotoxin or viral particles, then removal of cytokines, then organ support. In a recent publication, I'm sorry the image is not clear, but the Institute Mario Negri in Italy has provided the evidence that viral particles are present in the kidney. And therefore, we have the opportunity to create a model of kidney damage that will come out in Lancet Respiratory Medicine tonight at 11 o'clock. So you will be able to see this paper tonight in conjunction with Faik Hussein from Germany and Tiago Reis from Brazil, who is spending some time as a fellow at our institute here in Vicenza. By the way, all my greetings go to our fellows, Irivians from Colombia. We had many young fellows, and they were excellent students and collaborators. So this will be the title of the paper in Lancet, Management of Acute Kidney Injury in Patients with COVID-19. And this is the model that we have created. Infection goes to no symptoms or mild symptoms, but they may also evolve into specific symptoms that may have pneumonia, may have hypercoagulability, or lead to the cytokine storm, or the three of these conditions. These conditions, in conjunction with possible hypovolemia due to fever and dehydration, and direct damage to the kidney, endothelial, podocyte localization, proximal tubular localization, mitochondrial dysfunction, and acute tubular necrosis, may lead to kidney damage. Kidney damage may occur through endothelial dysfunction and also by filtration of damps through the glomerular membrane. At the same time, pneumonia may actually be further, let's say, aggravated by the presence of acute respiratory distress syndrome, and in presence of also ECMO or mechanical ventilation. This may lead to further damage to the kidney. In turn, hypercoagulability may cause directly damage to the kidney by endothelial damage, rhabdomyolysis, kidney infarction, and microthromby, and also a damage to the heart that through a myocardial dysfunction may cause arterial underfilling or venous congestion, leading to damage of the kidney. In turn, AKI may result in fluid overload, aggravating the patient. And in this case, I'm sorry, this is not hypovolemia, it's hypervolemia that may actually induce damage to the lungs. So we are in front of a situation where there is significant crosstalk between different organs, and we have available different options to support organs that go from VA and VV ECMO, slow continuous ultrafiltration, CRRT, plasma filtration, plasma exchange, hemoperfusion, albumin dialysis, plasma filtration adsorption, and extracorporeal CO2 removal. This is the algorithm that we suggested in our paper in Lancet. We start from the indication, suggesting that CRRT may be applied because of oliguria and refractory hypervolemia, but also hyperkalemia, severe acidosis, azotemia. But in presence of cytokine release syndrome, we should consider extracorporeal techniques for cytokine removal, like the one we have suggested before. Then we should prepare for these therapies. We should prescribe the therapy, CRT and other hemoperfusion techniques in case are needed. We should ensure that we have an effective delivery. And finally, we should monitor the treatment in a way that we can go back to delivery or prescription and modify prescription in case we're not achieving adequate results. We should see also that in China, National Health Commission of People's Republics of China have suggested blood purification treatment, including plasma exchange, absorption, perfusion, and blood plasma filtration to remove inflammatory factors in case of cytokine storm. Interestingly enough, recently, FDA in America has approved the emergency use of hemoperfusion with the Cytosorb cartridge for emergency use in COVID patients. This is a situation, therefore, of a patient that comes to admission with fever, hypotension, respiratory failure, starts mechanical ventilation, then evolves, possibly if severe cases are present, in hemodynamic instability, high cytokine level, high ferritin, high CRP, hypercoagulability. These are the patients in which we suggest to apply hemoperfusion to remove cytokines. And in fact, in some patients, we have observed hemodynamic stabilization, normalization of cytokines level, decrease in inflammatory parameters, improved pulmonary exchange, and extubation. And the PaO2 FiO2 ratio has improved dramatically. This is one case that I would like to report of treatment for 10 hours, in which we had 50% reduction in interleukin-6. We have 60% reduction in norepinephrine requirement and improvement in mean arterial pressure. But also, studying the monocytes of this patient, we have seen after 10 hours of treatment the improvement of the capacity to express TNF and the ability to do phagocytosis. Furthermore, we have seen the improvement in antigen presentation capacity determined by the measurement of HLA-DR expression. This is the mean fluorescent intensity, and this is the percent of monocytes expressing the HLA-DR. As I mentioned before, hemoperfusion can be done isolated or in conjunction with the CRRT using a filter after the cartridge or before the cartridge, and the circulation can be easily performed. Also, we can perform hemoperfusion in case of patients that require extracorporeal membrane oxygenation, and the treatment can be using a separate circuit or can be somehow connected to the ECMO circuit. There are key messages in our paper in the Lancet, and there are also research priorities. I would like to stress the fact that most of the treatments done in COVID-19 patients could not be tested in randomized controlled trials. I'm not sure that we will ever be able to do it because in the past we never did it. There are no money to do these studies. But however, we need to collect as much information as possible to clarify the role of hemoabsorption and other extracorporeal systems. To reassure you, we have strongly stressed the fact that these treatments are reserved for special cases or in the context of randomized trials. And we're going to do a special consensus conference with ADKI in a very, very short period of time. So those patients who have superimposed sepsis, we can apply the sequential extracorporeal therapies. Those patients who have viral infection, and because we know that viral infection can actually lead to significant virus levels in the blood, we can use also potential instruments like lectin absorption devices for viral particles removal. In conclusion, I think we have to tackle three different aspects of this patient: cytokine storm, the crosstalk between different organs, and the systemic situation. This is a figure that has been designed by Tiago Reis, showing that we can use hemoabsorption, we can use different organ support strategies, and we can also use probably CRRT, possibly with more open membranes like MCO or ICATOF membranes in order to remove also inflammatory mediators. I would like to ask you to follow our Cappuccino series. This is on YouTube, and you may like the different point of view that I often express. Interestingly enough, this Cappuccino was done in Wuhan in November 27, so we were almost ready to go with the pandemic. And as we mentioned before, you're all invited to come back to Italy on November 3 to 5 to our international course. With this, I think I can stop sharing my screen and go back to your moderation. Thank you.